So yes, I can see my slides. I hope I will be very short because we are running out of time. The lunch break is already, so I hope to make it quickly. I'm going to talk about the smart approach to surgical treatment of gastric and duodenum GIST based on the preoperative EUS-typing. A lot of things that we were discussing today already. So I will skip these guidelines we already discussed during a live case of Claudio, during a presentation of gem collages, some of them. The only thing I wanted to say, to emphasize here, is that the surgical treatment for GIST have some peculiarities. So the treatment of choice is a treatment of choice for resectable tumors. The objective of surgery is complete R0 resection always. So the routine lymphadenectomy is not required, which is a very important point for the treatment surgical strategy. And every effort should be taken not to rupture the pseudocapsule of the tumor. So the wide application of the minimally invasive techniques led to the development of the main two approaches: the laparoscopic approach, which allows to perform the surgery for the large GISTs, and endoscopic approach, including stair procedures. The most organ-preserving and functional technique, mostly for the small tumors. But there are always a problem, the choice of approach, as we discussed already today during the live case from OR. So the choice of approach mainly depends on the tumor size and the surgeon's experience and skills. So we analyzed the treatment of more than 200 patients with submucosal tumors, including 80 patients with GIST. And we, regarding to tumor location, shape, type of growth, and the type of the procedure. So according to these criteria, we create a classification for decision-making of the optimal approach based on preoperative EUS-typing. So the principles of this classification was based on the following criteria: location of the tumor base in relation to GI layer, size of the tumor base, the so-called growing point, and the type of growth of the tumor in relation to GI lumen. So I will quickly show you these types. Type 1, as you can see on the scheme and on the endoscopic and ultrasound images, it's a tumor with intraluminal growth. A tumor originates from the second layer, muscularis mucosa, and this tumor is immovable on endoscopic palpation relative to GI wall. So the optimal approach for this type of tumor is endoscopic submucosal dissection, if it's a large size, or endoscopic mucosal resection, if it's a small size, as you can see on the pictures. Type 2, as a tumor with intraluminal growth too, but this tumor originates from the third layer, from submucosa. This is for non-epithelial tumor, not only for GIST. So the tumor size could be variable. The optimal approach for this type are endoscopic enucleation of the tumor after resection of the covering mucosa, as you can see on the upper image, and endoscopic tunneling dissection. So removal of the tumor from the tunnel. So type 3, as the GIST that's originating from the muscle layer, the fourth layer. And there are some subtypes, which depends on the type of growth in relation to GI lumen, size of the tumor base, and the shape of the tumor. So type 3A, it's a tumor with intraluminal growth from the superficial muscle layer. I mean circular muscle fibers. So the size of the tumor base, or the growing point, which you can see here, this is the growing point of the tumor from the muscle layer. So in the muscle layer, it's less than 1/2 of diameter of the tumor, as you can see on this image. And the angle between mucosa and the tumor is sharp. And we can measure it on the EUS preoperatively. So for this tumor, the optimal approach is endoscopic tunneling dissection, as you can see here on the scheme and on the short video of this procedure. So we often use the endoscope, flexible endoscope, with the cap on the distal tip of the endoscope, And we start to open the mucosa to create the entry of mucosa in order to start to create a tunnel. We do the very classic technique with the injection of the saline into submucosa, with cutting the fibers in the submucosa so that we approach to the tumor itself. As you can see here, this is a short tunnel. This is the tumor, and we mobilize the tumor, cutting all the fibers around it. So this is the steps of the classic tunneling dissection in a stomach. And after the tumor is completely mobilized, we remove the tumor with a grasper from the tunnel into the stomach lumen and remove it from the patient. This is the tumor size. It's 2 centimeters. After that, we check the tunnel for any bleedings, and then we close the entry point, closing the mucosa with endoscopic clips. So the next type is type 3B. It's a tumor with intraluminal growth from the deep muscle layer. So the size of the tumor base and the muscle layer in this type is more than 1/2 of the diameter of the tumor. So, and the angle between the mucosa and the tumor is blunt. And you can measure it once again on EUS during preoperative study. So having this information before surgery, you can decide what to do to this patient. So the optimal approach is laparoscopic atypical resection after gastrotomy or duodenectomy, or endoscopic tunneling dissection. But this should be done by an advanced endoscopic surgeon, and in the cases of the small tumor size. So how we do this? This is the example of the patient with the tumor located in the duodenal bulb. So we start to do the laparoscopic mobilization of the stomach, of the antrum. And then we open the duodenal bulb, the anterior wall, with the ultrasonic scissors. So you can see very clearly the tumor. And very accurately, you remove the tumor from the lumen and complete the resection of the duodenum wall, not rupturing the tumor. So we remove the tumor in a container, in a bag, following the oncological principles. And then we close the duodenectomy with the hand sewing, with laparoscopic sutures. And that's it. So the next type is 3C. So on this scheme or these images, you can see that the tumor is going deeper on each next image. So the next type, 3C, is a tumor with both intraluminal and extraluminal growth. So it's located just like kind of in the middle of the GI wall. And the size of the tumor base corresponds to the diameter of the tumor. And the angle between serosa and the tumor becomes blunt. So this tumor could be visualized during laparoscopic approach, and the optimal choice is laparoscopic atypical or a patch resection. Like, for example, in this patient, the tumor was located in the fundus, as you can see on the scheme. And we performed a laparoscopic resection using a stapler, endoscopic stapler technique, as you can see on this video. So the tumor located in the fundus is really easy to remove with this very fast with using the staplers. And there's no risk for any problems here because we have a normal gastric wall here and no anatomical narrow spaces. So the next type is a tumor with extraluminal growth. It's a 3D. Tumor base originates from the external longitudinal muscle fibers, and the angle between serosa and the tumor is sharp. So this tumor is very easy to visualize during laparoscopy, and the best approach are laparoscopic enucleation of the tumor or a typical stapler resection. So here you can see the example with a patient with the gastric GISTS with the extraluminal growth. It's type 3D, very easy visualized during laparoscopy. So the growing point of such tumors is really small. So you can mobilize the tumor all around. And here you can see that most of the tumor is growing outside of the stomach. So this is the clipping of the feeding vessels. So these are the steps of complete mobilization. And after that, you can remove this tumor very easily using an endoscopic stapler. So as you can see here on the video, the growing point is really, really small. And just one stapler is used to remove this tumor completely. And if you notice, this was a patient in which we used the single approach and the curved instruments. Only one port for this laparoscopic surgery. So we use a hybrid laparoscopic approach sometimes. I will skip this. We'll talk about this on Thursday during the day on hybrid approaches. And this is on the slide our experience. 80 patients with gastric and duodenal GISTS, 62 with laparoscopic resection, 80 with endoscopic approach. And these are the results. All cases were the R0 complete resection. Here are the operating time, blood loss, hospital stay, no serious complications. The pathology is grade 1 in most of the patients, grade 2 in 4 patients, and only 4 patients required the adjuvant target therapy, and no recurrence in all patients during the follow-up from 2 months to 8 years. So these are the summary for these approaches based on preoperative EUS-typing. Thank you.
Спасибо большое, следовательно. Ну что ж, уважаемые коллеги, я думаю, что мы лишим следовательно вопросов, как хозяйку этого мероприятия, ну и предоставим слово для информации перед ланч-брейком. Пожалуйста.
Несколько информационных слайдов. Еще раз напоминаю для тех, кто подошел позже, про органограмму. Вы сканируете свои бейджи с 3 до 6 часов для того, чтобы получить баллы НМО. Не забывайте это делать. Каждый день начисляются баллы по 6 баллов в день по следующим специальностям. Я хочу напомнить, что сегодня на стойке регистрации можно приобрести билеты на наш social event. Он будет сегодня в арт-пространстве «Рукав» в 7 часов вечера. Я хочу сказать для тех, кто уже приобрел эти билеты. Трансфер от института до арт-пространства «Рукав» организован в 6:30 вечера после окончания конференции. Вы можете поехать на автобусе непосредственно на social event. Второй social event состоится на этой неделе 13 декабря, в пятницу. Билеты тоже можно приобрести сегодня для тех, кто приехал на нашу конференцию на всю неделю. И еще раз про трансферы. Время сбора в автобусе 18:15, 18:30, 18:30 автобус отъезжает. For international participants, we will have the transfer from the Vishnevsky National Center of Surgery to this social event in the art space Rukav. The bus pickup time is 6:50 to 6:30. The bus departure time is 6:30. Do not forget to take your tickets at the registration desk. Thank you.
Спасибо большое.
И последнее, да. Самое приятное, обеденный перерыв или ланч-брейк и осмотр выставки до часу дня. Минус первый этаж на входе здания в ИХВ. The lunch break and the exhibition hall is till 1 p.m. on the -1 floor at the entrance of the building.
Спасибо большое.
So we are moving to the next afternoon session, the EUS for HPV diseases. So I want to